This is Dr. Amy Ho, host of ACEP Nowcast. Before today's episode, we want to remind our listeners that registration for ACEP's 2026 Scientific Assembly is now open. Your specialty, your people, one place. Join us in Chicago this October and register now at acep.org/ACEP26 for free access to ACEP anytime.
Ryan Stant here with ACEP Frontline, and today we head back out to Beaver Creek, Colorado as part of our weekend playlist series for the 4th Annual Leadership Symposium and EM High Risk Do Not Miss Conference. And in this one, a practice update regarding beyond neutropenic fever, complications of immune-based cancer therapies with Dr. Abby Leibowitz. In this discussion, we talk about some of the changes with the advancements in cancer management and some of the things we need to do as physicians in the emergency department with regard to questions and line of thought with some of these changes in therapies, because the risk factors are different. It was pretty easy back in the day because they were on chemotherapy that was trying to kill the cancer cells before it killed the patient. And so pretty much most neutropenic fevers were the same. Not so fast today. It's a little bit different because of the updates in many of the immune therapies and cancer medications that are out there. So checking out Beyond Neutropenic Fever, Complications of Immune-Based Cancer Therapies on our weekend playlist here on ACEP Frontline.
So for our roadmap today, it's really pretty simple. We are not going to talk about tumor lysis syndrome, neutropenic fever, all the stuff that you learn in medical school. We are going to talk about immune checkpoint inhibitors and CAR T therapy. And the idea is not that you're going to walk away as an expert, but really that you're going to get exposed to this, hopefully understand a little bit about how they work, be able to intuit through some of the side effects, and then have a more effective conversation with your oncologist, your hospitalist, so they can actually get you the treatment or disposition plan that you need. And the take home here is that it is not enough to say this is a patient with breast cancer on therapy, right? We have to know at this point what kind of therapy someone is getting, because they are vastly different. So not all cancer treatments are equivalent. And indeed, immunotherapy is really a paradigm shift in the oncology world, right? With chemotherapy, it exerts effect through direct toxicity. So you're just poisoning the body with the idea that the cells turning over the fastest, your cancer cells, are going to be most affected. But in immunotherapy, you're activating the immune system to go and do the killing. So the drug itself has no toxic effects. And it can be very broad-based in the way that it upregulates the immune system, or it can be very targeted. And so it also opens the door to precision therapy here. So these sort of baseline differences are going to inform our side effects. With chemotherapy, we know that this is just immunosuppression. That's the big thing to look for. With immunotherapy, the main thing that we're going to look for is immune overactivation. These patients will still be immunosuppressed to some degree, but that is largely resulting from their underlying disease or the other medicines that they're on. So if they got a combination chemotherapy and immunotherapy, their immunosuppression is really from the chemo. It's not from the immunotherapy itself. And if you look at the literature, it's very clear that emergency physicians do not feel comfortable with this. There was a survey out of Indiana that said, hey, EM residents, how competent are you at identifying side effects of immune checkpoint inhibitors? And it was a 1 out of 10 on average. Attendings in Italy, not much better. They said we're 3 out of 10 competent. And in that same study, 40% of emergency attendings said, I don't routinely consider the type of cancer therapy that someone is receiving. So let's talk about immune checkpoint inhibitors. So the first one, Yervoy, was approved in 2011, and there are about 10 of these out there now. Listed up here are the 3 most common ones that you'll see: nivolumab, Opdivo, pembrolizumab, Keytruda, and ipilimumab, Yervoy. These are given as an infusion, typically every 2 to 6 weeks. Although just a couple weeks ago, Yervoy, there was a subcutaneous injection that was just approved. So before I jump into the side effects, I just want to point out immune checkpoint inhibitors are a subset of monoclonal antibodies that happen to work on the immune checkpoint mechanism. And the monoclonal antibody class is really broad, and those effects can be totally variable. So for instance, Humira, Remicade, Enbrel, they are all TNF-alpha inhibitors. And so they block a excitatory part of the immune system. And so they have a ton of immunosuppression as their side effects. Whereas trastuzumab, that's a HER2 blocker. And so you see very minimal immunosuppression. So yes, you can think about mAbs as being a class, but know that it is a really variable class. Before I sort of talk about the actual therapy, we need to know how this works in the real body. So normally, T cells are going around, they're seeing different antigens, and when they identify an antigen as foreign, whether or not the T cell actually activates is based partially on co-stimulatory, co-inhibitory mechanisms that are next to it. And so if a T cell sees an antigen and says, hey, this is not normal, this is foreign, but at the same time, PD-1 or CTLA-4 are activated, the T cell itself will not respond. And if it does, it's very, very muted. So this process, this inhibitory signal, is really important for us to not all be walking around with autoimmune disease. This is how we develop peripheral tolerance, but a cancer cell can hijack it so that it can essentially hide from the immune system. It will upregulate these sort of ligands or receptors to be able to say like, hey, T cell, you really don't need to worry about me. Just go about your business. And so what an immune checkpoint inhibitor does is it's a monoclonal antibody that binds to either the receptor or the ligand, and that happens to be PD-1 or CTLA-4, so that you can't have that inhibitory interaction. So as soon as the T cell recognizes the antigen on that tumor cell, it goes ahead and activates. And in essence, you're giving your T cells permission to go out and fight throughout the body. You're not changing what they do after that, but you're just giving them permission to go fight. Now, because you've unleashed your immune system, all of the side effects look like autoimmune disease. If you can call it an itis, it's probably a side effect of this. Keep in mind, though, that the different agents have different proclivities for these various side effects. So Opvito, for instance, is the most likely to cause encephalitis, whereas Yervoy is the most likely to cause colitis. So that's where your oncology team can help you, but know that they're not all identical. So each of these immune checkpoint inhibitor side effects is given a grade, and it's graded according to the American Society for Clinical Oncology. And these are not just like a research grade that goes into a void and no one cares about. This grade will determine what kind of treatment they get. And for immune checkpoint inhibitors, in general, if it's grade 1, it's supportive care. And those patients are probably going home without patient follow-up. If it's grade 2 or above, that's where they're going to get steroids and maybe get admitted. And so if you're worried about a particular side effect, you're like, I want to know about colitis, just Google the grade, and it will give you all the information you need to then feed your oncology team during that consult conversation. So let's go through a few cases. This is actually a gentleman I had. He was a 67-year-old on ipilimumab for the last 4 months for renal cell carcinoma. He was coming in with 2 days of diarrhea and abdominal cramping. He had around 6 stools a day, and nothing else really was going on. Vitals looked great. His belly was soft, but mildly tender throughout. His CBC was normal, ANC 2.1. BMP looked great. Stool PCR was negative, and the radiology read was like the classic, this is abnormal, but IDK. Infectious versus inflammatory enteritis. In any other patient, this guy is probably going home, right? Mild diarrhea, tolerating PO, keeping up with all of that. But in this guy, it's a case of ICI-related colitis. The onset for this is typically 5 to 8 weeks after starting therapy, but the range here is super wide. So for these side effects, I think about any time from when the immunotherapy is started to like 2 years later. It's about a quarter of patients who get colitis, and even more will experience isolated diarrhea. This is the grading system, and the reason I show this is because never in my life have I cared about the difference between 4 stools and 7 stools a day. But in this, your oncology team may want to know the answer in order to grade them more appropriately. So this gentleman, even though he looked great, was grade 2 and got admitted for IV steroids and further observation. So next case. 67-year-old male on pembrolizumab for the last 9 months for melanoma, comes in with dry cough, shortness of breath with exertion for a week, no other symptoms. His vitals are stone cold normal, his exam looks great, and his workup is absolutely pristine. In any other patient population, this guy is like out the door already, right? But this is highly concerning for ICI pneumonitis. And the median onset is 8 to 9 months after therapy, but again, super wide. It is much rarer than colitis, only 3% incidence with PD-1 inhibitors, but it's one of the more common causes of death in these patients. And for me, the way it changes practice to know about this is these patients need a CT scan of their chest, right? Because their grading is based on partially how much is involved on that CT. And by the time they get to you, they are probably symptomatic, and so they're already a grade 2. For the next case, this is a 67-year-old gentleman on ipilimumab for 2 months for melanoma, coming in with headache, poor appetite, fatigue, and nausea. His labs are notable for a new mild hyponatremia. His wife is like, yeah, he hasn't been eating very well. He doesn't feel good. What do you expect? His TSH and his T4 are a little low, though. This is a case of ICI-related hypophysitis. And I bring this up because never in my life do I think about hypophysitis, except in this case. So it is actually a 3 to 17% incidence with CTLA-4 inhibitors. The median onset is 2 to 3 months after therapy, again, broad range. And symptoms are really vague, right? It's that person who just doesn't feel good. Headache, fatigue, generalized weakness. You can see nausea and anorexia. You're typically not going to get bitemporal hemianopsia or any of the visual stuff because the degree of enlargement of the pituitary is actually quite small. Hyponatremia is common and might be a clue to you in someone who's saying these vague symptoms with a headache that they need a further workup. This patient at some point needs an MRI brain with and without. And that doesn't have to happen in the ER, but I think rarely am I thinking this generalized weakness needs an outpatient MRI brain. And so this is a good step to know about for setting them up for success. In general, endocrinopathies, super common with immune checkpoint inhibitors, and unfortunately, they're typically not reversible. So many of these patients will need to be on hormone replacement for the rest of their life. And just going back to the case for a second, we obtained a TSH and T4 in this case. If you're worried about hypothyroidism in these patients, you should get both off the bat because of the concern for possible central hypothyroidism. So case 4. This is a 67-year-old male on nivolumab for the last 5 months for renal cell carcinoma who's coming in after a first-time seizure. He's now back to his baseline. His neuroexam's totally normal, vitals are fine, his workup looks great. And there's a plan for outpatient MRI brain with and without in 3 days. This was a patient we saw in the emergency department. And so the team discharged him with that MRI plan for a few days from now. And then he ultimately came back with ICI-related encephalitis. Neurotoxicity is pretty common, and it can take a wide variety of forms. And in general, the workup is going to be pretty similar, right? You're not going to miss the myasthenia gravis, the Guillain-Barré. That person is going to get admitted. They'll get more workup. The mild peripheral neuropathy, it's probably going to be observation anyways. You can send them out. I think isolated seizures is the one where we have the potential to get a little bit tripped up. Isolated seizures in an ICI patient probably needs more than our typical workup. And these are going to happen in about 4 to 6% of patients. For the seizures, it will depend on your neuro and onc team, but a lot of them at this point will get MRI, LP, and then once the LP is negative, then they will start them on steroids. Part of the question is, do we need to rule out some sort of weird meningitis before we start this patient on 1,000 of methylpred daily? Chest x-ray is not particularly sensitive, so it might, but a normal chest x-ray does not rule this out, unfortunately, which is why I think it's good to know about, because otherwise I would have just chest x-rayed them. All right, so CAR T therapy. So the goal of CAR T is to create an army of T cells that can then go around the body and recognize cancer cells more effectively based on their possessing a very specific antigen. So whereas ICIs, they're upregulating the immune system, allowing them to fight, but it doesn't change the way that your body identifies tumor cells. T cells are changing the way that your body identifies it. So the way this works is that patients first undergo leukapheresis. So they get their T cells sucked out, and then those T cells get sent to a lab where they get engineered to express a specific receptor. And which receptor they get corresponds to their CAR T product. So every CAR T product has a specific receptor. They will then get grown up in the lab and infused back in. That whole process takes about 2 to 5 weeks. And so in the meantime, a lot of these patients get bridging chemotherapy to keep their disease at bay so that they are stable enough to actually get this infusion back. And then right before they get the infusion, even if they didn't need the bridging chemo, they'll get lymphodepletion chemo. So usually cyclophosphamide and fludarabine. But so these patients are now a combination of agents, essentially. The first CAR T was approved in 2017, and there are 6 of them on the market. They all end in Lucell. That's going to be the key here if someone doesn't tell you. And the indications right now are lymphoma, leukemia, and multiple myeloma. But these are being studied across the board. In solid tumors, they're being studied for refractory lupus, refractory Sjogren's, and as first-line agents. So right now in Colorado, there are 3 places that do this: Presbyterian St. Luke's, UC Anschutz, and Children's Central Campus. And before I lose 90% of the room, that was because the FDA, when this first got approved, required a risk evaluation and mitigation strategy. So the FDA was like, this is super new, we don't know what's going on, and so you need to be at a certified treatment center, and patients need to stay in 2 hours of that treatment center for the first 30 days. That got lifted at the end of June. And so the FDA essentially said, we know enough about this to put a black box warning and then let the community handle it. So at the U, there is significant talk of having patients leave after only 14 days. And there's the ability for other centers to start doing this. So I think over the next few years, this is going to expand fairly rapidly. And we know that these recipients come back to the ED. So in a study out of Houston, which has amazing outpatient cancer treatment centers, and they do a ton outpatient, 42% of patients had an ED visit within 6 months. And then of the patients that showed up, a third of them were dead by 90 days afterwards. That's a really sick patient population. Hopefully it'll get less sick as we start to use it more broadly and it's not just saved for the refractory disease. But when that patient shows up in your ER, they're a sick person. Before I go to the side effects, I just want to mention really quickly bispecific antibodies. You can think of this as off-the-shelf CAR T, because instead of engineering your own cells to identify tumor cells, it basically gives you an antibody that in one hand can bind the tumor cell, in the other hand can bind the T cell, and when they're both together, it can activate the T cell. So if you ever see this, just think to yourself, this is kind of CAR T. So this is the first side effect, cytokine release syndrome. It is similar to sepsis or HLH. It's overactivation of the immune system, and its predominant feature is fever with or without end organ dysfunction. It happens within a month of infusion, so historically we were catching almost all of these in the admitted patients, but you will notice 14 days is shorter than that. And it looks like sepsis. In fact, sepsis can coexist with this. Higher grades of CRS are more likely to have an underlying bloodstream infection. The reason you need to know about this is there are additional treatments beyond what you're going to give your typical sepsis patient that might need to get mobilized. Because it's immune overactivation, the treatment is to tamp back down the immune system. So tocilizumab, Decadron, anakinra. The other thing to know about is expert opinion is that because there's so much capillary leak in these patients, if they're in shock, you should move earlier towards pressors. So if you have this patient, you're debating that third liter versus pressors, just start the pressors. Ultimately, which treatments they get depends again on their grade, and the grading is really simple. It's based on their blood pressure, were they hypotensive and got better with fluids, do they still need pressors, and what's their oxygen requirement I think to me, if I'm admitting someone and they're on room air versus 1 liter nasal cannula, I really could care less, but that's actually going to change their grade from grade 1 to grade 2. So just to drive this point home, I want you to think about a 23-year-old male with refractory ALL who's coming in on day 23 after CAR T infusion. He's got fevers, malaise, myalgias. He was discharged on day 14, and he's got no other symptoms. The only thing you find is that he's febrile at 38.2, and his labs look fantastic. You can't find anything. In a patient who got chemotherapy, this can probably go home. Even if they had a neutropenic fever with good outpatient follow-up and antibiotics, they can probably go home. This, with potential for CRS, needs to get admitted for further monitoring. So the next main side effect is immune effector cell-associated neurotoxicity syndrome. I definitely had to practice that one. Everyone calls it ICANS. This is a global encephalopathy picture. It's unclear if it's just blood-brain barrier disruption or the T cells actually infiltrating? No one really knows. But you'll see encephalopathy, language dysfunction, movement disorders, and then it can get really severe with seizures, obtundation, elevated ICP. It normally resolves on its own, but there are a fair number of deaths from cerebral edema related to this. The most specific symptom is the language stuff. And so of the people who progress to really bad ICANS, 86% of them will have expressive aphasia. This typically occurs within the first 30 days, although after CRS, so it's a little bit later. So to determine their ICANS grade, everything is pretty intuitive, like level of consciousness, have they had a seizure, do you think they have elevated ICP? The one that is unique on here is the ICE score. And just so you're aware, this is a 10-point score that your oncology team will use. And if you do a thorough neuro exam, you're going to get to most of these except the writing or the attention. Those are the two that I probably wouldn't do. And then remembering to have them name some objects I might also need to do. So the median onset for CRS is a little bit earlier than ICANS. A lot of the people with ICANS will have concurrent CRS, but not everyone. But if you look at like median onset times, CRS is a little bit earlier. The reason just to know about this is if their neuro exam is pristine, except they have difficulty with handwriting, they get admitted and get steroids, right? Like that's a pretty nuanced finding. And so being aware of this can be helpful. And this is just an example of a patient with ICANS who had pretty profound difficulty writing and then immediately recovered after getting some immunomodulators. Diagnostics, you are going to try to rule out all the emergency medicine stuff. Do your normal job. The CT head and MRI, if you get it, may be normal. And if it is abnormal, it's going to be nonspecific. Like your radiologist is not going to say, this is ICANS. LP you may or may not need, especially if they're thrombocytopenic, you're probably not going to get it. But if you do it, please get an opening pressure because cerebral edema is part of that grade. And so knowing whether or not their opening pressure was elevated will help your colleagues upstairs. The treatment, again, is going to be immunomodulators. Tocilizumab typically isn't used because it doesn't cross the blood-brain barrier, but Decadron, anakinra, and then in a lot of institutions, prophylactic Keppra, although it's pretty controversial. The first month, this is going back to your question, is the highest risk, but the median onset for CRS is a little earlier, ICANS a little later. 10% of patients who have ICANS, though, are going to start after 3 weeks. And so that's after they've been discharged. And these side effects, really common. The high-grade ones, obviously a lot less so, but most patients will get some degree of CRS or ICANS. And then in multiple myeloma patients specifically, there are movement and neurocognitive toxicities as well. And it can range literally anything in your neurologic spectrum. Myelopathy, cranial nerve palsies, peripheral neuropathy, personality changes, Parkinsonism. This is later onset than CRS or ICANS. It's usually after a month. And there are case reports of it like 2 years later. 12% of patients who get CAR T for multiple myeloma will get this. And the reason to know about it is like a new Parkinson's diagnosis potentially is going to get a neuro call and probably go home with rapid outpatient follow-up. But these patients might need intrathecal chemotherapy. Like it's a whole different treatment regimen. And then if you have cranial nerve palsies, they might get IVIG as well. So the key takeaways here, immunotherapy is fundamentally different from chemo. And all of the complications are really because we're just revving up the immune system. For the immune checkpoint inhibitors, if you can call it an itis, it's probably a side effect. For the CAR T, you want to think about CRS, ICANS, and delayed neurotoxicity. And then the side effects of immunotherapy are going to be treated with steroids. And so while you're going to do your job to get rid of everything else on that differential, you just need to know that this may require admission for some of these additional treatments. Well, thank you all so much.
An ACEP Frontline weekend playlist with Beyond Neutropenic Fever, Complications of Immune-Based Cancer Therapies with Dr. Abby Leibowitz from the 4th Annual Leadership Symposium and EM High Risk Do Not Miss Conference in Beaver Creek, Colorado, coming up once again the first weekend in November in 2026 at Beaver Creek. I'll be there speaking one of those days, so feel free to join us for some fantastic education. I invite you to download and save the podcast, subscribe to the podcast on your favorite player. Please give us a 5-star rating, help boost our list. And until next time, I'm Dr. Ryan Stanton, and this has been some ASAP Frontline.
And in the silence, you will show me who you are.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all alone. Da, da, da.